Hi, this is Dr. Bernard Beldholm, and in this video we're going to talk about the complications of circumferential hybrid abdominoplasty, which is a combination of the vertical and circumferential abdominoplasty. First of all, I'll go through what it is, so you have a better understanding, and then we can go through what the complications are. So the circumferential hybrid is combining a circumferential abdominoplasty or circumferential lipectomy or 360-degree lipectomy with a vertical excision. So it's like a fleur de lis together with a circumferential, because there's a big difference in the traditional operation. So if you just do the bottom circumferential, then there's going to be loose skin in the middle that doesn't get rid of. If we just do the fleur de lis, then we are fixing the middle and lower part, but not the flank and not the back. So by combining those two operations, we can basically get rid of the skin in the front, tighten that, the horizontal excess skin, as well as pulling the skin down and fixing up the circumferential flank, back and buttock area or gluteal area. So that is a really good operation. It is quite a long operation, but certainly a really good operation for post-weight loss patients that have significant amount of loose skin in those areas. It's really important that you have good nutrition, good fitness, there's no other major issues, because it does take a long time to recover, and your body really needs to be good beforehand to get a good recovery afterwards. Now, complications is what we're talking about today, not the actual operation, but that's an overview of the operation. If you group complication, you group them into local complications, which is the wound and the actual operation, and then general complication that can happen with any operation. So we'll start talking about the local complications for this procedure, and then we'll go on to talking about just sort of general complications that can happen with any operation. Wound healing issues, wound healing issues, wound healing issues, wound healing issues. By far, that is what we deal with in and out, day and night. Wound issues. Okay, so really the biggest percentage of issues tend to be wound related, and especially with an operation that is this big, you have area all the way around, you have one in the middle, belly button, the junction between the incisions, the natal cleft or the buttock crack is the areas that do tend to break down quite a bit. Those can take a while to sort out. The next one there is seroma. Anytime we cut anything in the body, I create a space. Now the body wants to fill spaces with fluid, and that's why we use drains to drain away the fluid. If we take the drain out, which we do a couple of days later, and the tissues are not quite healed, that tissue can accumulate fluid again, and you get a fluid collection. And that fluid collection is called a seroma. The treatment for that is to put a needle in and pull the fluid out, and we may have to do that for 2 to 3 weeks, 2 to 3 times a week, just until it goes away. Sometimes, very rarely do I have to put in a drain to drain away the fluid, but that's not that common for me to have to do that. The other one is infection. Now, we spoke about the wound infections. However, there are other infections you can get as well. By far the most common infection is a superficial wound infection, and usually oral tablets is all we need to do for that. Sometimes if it's a spreading infection, MRSA, some serious infection, or where you have systemic symptoms like shivers and fevers and things like that, you may have to go back to hospital to sort of get IV antibiotics and get a bit more aggressive treatment. If the infection is deep in the tissues, you can get what's called a collection or abscess. So just think about the pimples you squeeze, you get that pussy stuff, that happens on the inside. Now with these operations, pretty much all the big body contouring operations, they are creating a big space on the inside. And that big space, if it gets infected, there can be a significant amount of pus or collection of bacteria that forms in that, and you can get very, very sick if we don't treat it. So if you have an abscess, you have to go back to operating theater. Antibiotics do not treat an abscess. What we need to do with that is basically reopen the area, wash the area out, usually with antiseptic solution. Then I put 2 big drains in, then you will be in hospital for a little bit. As part of the operation, I'll send off some wound swabs. Those take 2 to 3 days to kind of come back so that we can target your antibiotics for that bug. This is not a very common thing that happens. I probably have maybe every couple of years we have an abscess, but certainly it's definitely something that needs to be treated very, very seriously. I need to make sure that we get you back to operating theater and we get you back into the hospital. And this is one of those reasons why having private insurance and being covered is important, because we can treat it quickly and we don't have to worry about do you have to pay for it, all that sort of thing. Now, the other one is bleeding and hematoma. Now, with the circumferential hybrid, obviously there's a big area of incisions and space. If you get bleeding and that bleeding goes into the tissues and collects, then you get what's called a hematoma. So that's a blood collection. What I need to do with that is stop the bleeding and get rid of the blood collection. If it's a small bleed, so you bleed and then it stops, you might get extensive bruising in one area and then it stops and you're stable, the blood pressure, everything is stable, your hemoglobin doesn't drop too much. We can usually observe that and not do anything, but if you continue bleeding, your blood pressure is unstable, your hemoglobin is dropping, then we have to take you back to operating theater, open that area up, find the bleeder and then tie it off and wash all the blood out of the tissues, put big drains in again. That will help get rid of the blood. A lot of times when you get bleeding, you get blood in the actual tissues. So you may not, I won't be able to get rid of all the blood in the operation, but then after the operation with the drains, quite a bit of blood will come out of the drain from that tissue. When I make cuts, I will cut sensory nerves, and there's lots of different little nerves in the abdominal area and nerves that come on into the leg area and those sort of things that is going to be affected. So it's normal to get numbness in the areas that we've lifted up. That's kind of not so much a complication as expected. The numbness tends to take 3 to 6 months to come back. Most of the time it does come back. You can get intermittent nerve-related pains like shooting pains, stabbing pains, that sort of thing, because we may have stitch around the nerve, scar tissue goes around the nerve, and you get like that little pulling sensation or issues with the nerve. Most common area tends to be the front of the thigh, because the nerves come across this area and we are cutting across those sensory nerves a lot of times. And that's the most common sort of scenario. Sometimes in the side of the chest. I haven't really experienced it so much in the buttock area or the back area, but again, those can happen as well. When I'm doing the circumferential hybrid, we're doing it similar to a fleur de lis in the front. So we're going to incorporate the belly button into the incision line. The belly button area tends to be the one that has a lot of, it swells up, you have a circular incision, it does tend to break down a little bit. So I tell everyone, the belly button looks terrible for probably a good 4 to 6 weeks after the surgery. It's a little bit pussy, it's usually got a few little breakdown areas, it's swollen because it tends to swell up after the surgery as well. We just dress it and clean it and take good care of it, but try not to look at it too much because it does take time for that to settle after the surgery. So that's something you need to keep in mind. It is your own belly button. I can create, and I do sometimes create, a new belly button, but most of the time we shorten your own. So with weight loss, a lot of times you have a very prolonged stretched out belly button. So we'll shorten that and tie it down a bit so that it becomes an innie and then becomes a little bit tighter into the tissues. But sometimes if it's really necrotic or it's really stretched or it's got a big hernia or something like that, I can create a new belly button with a little flap and tie that into the tissues so that you get a different belly button from your own. But again, that is not the common one. Scarring. there's going to be lots and lots of scarring and you're going to have a long incision. So that's something you do have to accept when you go in for this operation. You're going to have an incision from the top down to the side and then all the way around your waist and back area. Everyone heals different with scars. We all hope that the scar is going to be a nice fine line. That does not always happen. Most of the time there's bits of the scar that are a little bit raised and bumpy and not as good as other areas. So that's something to keep in mind. I will do some scar revisions, and we can, once we get through this whole scar maturation process, we can think about steroid injections and things like that to try to improve those little bumpy bits that do happen. So scarring is kind of a little bit unpredictable. I try to plan it so it's in the underway line, but the vertical scar is always going to be obvious. Abdominal wall and muscle related issues. We can do a lot of other things together with this operation. So hernias, muscle repair, scar revisions, all that sort of thing in the area that I'm treating. The abdominal wall and muscle related issues. So if I'm doing a muscle repair, obviously that can fail, so that's a complication. The percentage in the literature is about 10% failure rate. I think it's probably a little bit lower, and it depends a lot on the size of the muscle separation as well. There is other plication things that I do as part of the operation as well. With a lot of patients that have had a lot of weight loss, they've stretched out the tissues a lot. So even though we might do the muscle, the abdominal wall itself sometimes is very stretched out, and we do plication sutures on the abdominal wall to tighten the abdominal wall up. Sometimes that can cause pain and discomfort and tightness and shooting pain, sharp pains when we do those, and that's part of the post-op complications that can happen. There might be a bit of restriction on movement initially. You might feel a bit of tightness when you come up. Most of those things do tend to settle over time. If I'm doing liposuction or suction-assisted lipectomy, I tend to use vasal liposuction, which is also referred to as ultrasonic suction-assisted lipectomy, and that's in 3 steps. So we're doing wetting solution, which has the local and adrenaline in it. Then we have the vasoring, and then we have the sucking out of the fat. So those are 3 stages. Liposuction has a big, long cannula that you are putting through the tissues. So you're going to get bruising, you're going to get possibly swelling from it. There's going to be a little bumpiness a lot of times before that settles. Once those areas start healing, you get a bit of hardness as well in those areas. Numbness can happen over where we've done the liposuction. Sometimes, very rarely, do you get skin color changes from liposuction, or you definitely get some temporary discoloration that tend to settle. Sometimes that can be long term. If we're not careful, then the cannula can go intra-abdominally, and that can damage liver, spleen, bowel, that sort of thing. And that's very uncommon, but it has been described in the literature and certainly has happened. So that's something we have to be very careful of when I'm doing the liposuction. So certainly can be some liposuction related complications. I don't do liposuction with everyone, and especially not for these big operations, because we are cutting a lot of skin out. I find that a lot of times that the thick areas or the areas with fat in them, they tend to be the ones that we're cutting out. So we don't actually need to do the liposuction. Skin necrosis. What is it? When I'm cutting skin and lifting skin and elevating skin, we are cutting some of the blood supply. If the remaining blood supply is not enough to cover the skin, then you get dead skin. Dead skin goes black, and you have to cut that dead skin out for fresh skin to be able to be healed. When you get necrotic skin, the steps for treatment will be, we cut the necrotic skin out, then we treat it like a wound breakdown. So dressings, wait for it to heal, go back to operating theater and restitch and recut. If it's a very big area, you may have to do skin grafts and things, but that is very, very unusual. Usually with the dressings and and further surgery, you should be able to put that together. That's a long discussion about local complications. Now we have all the general complications. So Usually because it's a big area, I usually focus a lot on the local complications of the actual operation, but we also have clots in the leg, lung issues, breathing problem, anesthetic complications. With anesthetic complications, you can get reactions to drugs. If we're doing liposuction, you can get local anesthetic toxicity if we don't look at the levels very well. And one of the big anesthetic complications would be a lot of nausea and vomiting after the surgery. My nieces tends to use the intravenous anesthetic, and if you are prone to nausea and vomiting, then we tend to get you preventative meds after to try to reduce that, because obviously having that with this sort of operation is going to be very uncomfortable for you. If we look at the main ones that you can do something about, so DVT and clots. What is that? Well, it's clots in your calves when you've been still for a long time. And that's the main thing there, is the calf squeezes, the blood thinners, and getting up and mobilizing afterwards as soon as possible. Because it's a big operation, I tend to give Clexane or the blood thinners for 2 weeks after the operation. So it's something that you go home with and you inject yourself just to try to prevent the clots from happening. If the DVT happens, tends to be around about the 2 week mark, so 1 to 2 week mark. So that's kind of what we're trying to prevent from happening. The second one is the lungs. Because you have a big operation and it's painful and difficult to move around, the body doesn't want to breathe. So if when you breathe big breath, you're going to have pain. So then the body wants to take shallow breaths. If you take shallow breaths, the bases of your lungs, they collapse. Once they collapse, they fill up with fluid, you get atelectasis, which is lung collapse, and then you get sick and you get pneumonia and you get other things happening. And that's why we use the incentive spirometry, the one that we really get you to suck on to expand your lungs after the surgery. Those two things, lungs and mobilizing, something you can help. And the quicker you're up out of bed after the surgery, the quicker I find that you're going to get home and the quicker you're going to get your recovery in. So that's an overview of the local complications as well as the general complications. I have videos about the recovery as well as much more videos about the actual operation. I hope you find this useful. If you come and see me, make sure you do an online booking. You'll also get information sheets and you'll get a consent form with all of these things, and we go through detail about these complications as well that are possible and what we can do to reduce them as much as possible. I'll see you in the next video and have a wonderful day.